We are getting to the last session of this very interesting scientific program of Saturday. And it's an honor for me, and also for my co-chair, and also for Professor Vassilikos, who is chairing from Thessaloniki, that we are privileged to have the Professor André for the last lecture of this day. The title will be Ablation of LV Summit Ectopic Tachycardia Focus, Methods to Improve Success. Before you step up in the podium, I would like my co-chair, Dr. Kolovos, would like to mention some very important things about your CV. I'm an interventional cardiologist, so electrophysiologists are more prone to you, so you will make the introduction.
Yeah, I think it's probably the best way to finish the second day of our amazing conference with this lecture. It's an honor to present the next speaker, Professor André, who is the head of the Department of Cardiovascular Sciences at the University of Leicester, consultant cardiologist and electrophysiologist at Glenfield Hospital, and president-elect of the British Cardiovascular Society. Professor Ang has revolutionized the way heart treatments and procedures are done. He has a distinguished research profile in investigations into cardiac electrophysiology and arrhythmia mechanisms. He has translated important preclinical findings into investigations in cardiac patients with the successful development of a novel technology for sudden death risk stratification, the LifeMap, which won numerous prizes, including Medical Futures Award 2011, Best Innovation in Diagnostics and European Heart Arrhythmia Association Inventors Award 2016, resulting in 2 internationally granted patents. Professor Ang, welcome in Greece. I think the stage is yours.
Thank you, Chairman. Ladies and gentlemen, I'd like to thank the organizing committee, especially Dr. Tagulis and Dr. Kolovos, for the very kind invitation to this fantastic symposium. And the lovely city of Athens. This is my first visit to Athens, although I've been to Greek islands before, so lovely to be here. I'm mindful that you've had a long day, and I'm standing between you and dinner. So I would try to be very precise and concise, but I've been given the task to talk about LV Summit VT and ventricular ectopics. Let me see whether this is going to work. Oops. Okay.
Okay. Just point.
Yeah, just point there. Okay, these are my disclosures. Okay, I don't know whether this is going to work. So I'm going to focus mainly on normal heart VT, or ventricular ectopics in normal heart. So we can think about this in an anatomical scenario where we can have right-sided normal heart VT coming from the RVOT, and if it's in the right ventricular outflow tract, then the ECG will look like that. I'm sure you're very familiar with that, with a left bundle branch block morphology on the ECG and an inferior axis, which gives us a clue that this is coming from the right ventricular outflow tract. On the left-hand side, normal heart VT would normally be what we call fascicular tachycardia. So because it is coming from the left heart, so V1 will be positive, and it's a right bundle branch block morphology with a left axis deviation being the commoner type coming from the inferior fascicle or the infraposterior fascicle of the left ventricle. In addition to anatomical classification, we can also think about these normal heart VT in terms of their response to drugs. In the previous slide, you see the RVOT is adenosine sensitive, whereas fascicular tachycardia is normally sensitive to verapamil. There are also normal heart VTs which are sensitive to beta blockers. But when we look at the normal heart VT, the majority of them obviously come from the right ventricular outflow tract. But you can see there's a significant number in the red box that actually come from the left heart. It could be from the left ventricular outflow tract, from the aortic sinus of valsalva or the aortic cusp, or they can be coming from the left ventricular epicardial surface, or they can be accessed through the coronary sinus venous vasculature. So this is an oldish paper from about 20 years ago. You can look at that, saying that the left ventricular source is perhaps about 18-20% of what we see in clinical practice. But as we now know, more and more difficult right ventricular outflow tract, or those who recur, we actually know that they are coming from the left heart, especially from the aortic cusp. So this is not a very rare occurrence that we find that increasingly we see more and more coming from the left heart. Why is that the case? Patients may present with right ventricular outflow tract, but actually the source of the VT or the ventricular ectopic is from the left ventricle. And that's because the left ventricular outflow tract is very close to the right ventricular outflow tract. So this is an anatomical image of the right ventricular outflow tract marked as red, the muscular origin of the RVOT. So if you take the RVOT and the pulmonary artery away, then you can see that it just behind, in terms of the musculature around the LVOT and the cusp, which is also marked in red, is very close to the RVOT. So that means something coming from the LVOT, from the left, can exit through the right ventricular outflow tract and give you an ECG that looks like it's coming from RVOT, but the source is actually from the left. So this is important. Can we just go back one slide, please? It seems that it's automatically doing it. So we are now calling these the left ventricular summit substrate. And the left ventricular summit is actually the top part of the left ventricle in the anatomical position of the heart in the chest, the highest point of the muscle in the left ventricle. So this region, which is the left ventricular summit area, is at the top. And we can see that this area is quite complex, and there are some important and potentially dangerous structures there. There are important arteries, important veins there, and also it's quite complex. There are epicardial structures, it's fat around the surface, and it's next door to the aortic cusp. You can see that it could be coming from the left or the right outflow tract. It could be coming from the aortic cusp. And in the left ventricular outflow tract, it could be above the valve, supravalvular, or it could be below the valve, which is infravalvular. And equally, the source of the VT could be epicardial, which is less accessible, or endocardial. So how do we determine, before we go into the heart, that we're going to have an easy day and order early lunch, or we're going to have a tough day and maybe have more time in the lab? The first thing I think we would help to see whether this may be an epicardial or an endocardial focus is this ECG index called the MDI, or maximum deflection index, using the QRS complex in lead V3 during the VT or the ectopic. So we measure the beginning of the QRS complex to the peak of the R wave in V3 of the ectopic, and measure that as a proportion of the total QRS duration. If that's more than 55%, then it's more likely to be an epicardial source. That means if you're ablating from the endocardium, it may not respond as well. And that's because the activation is slow before it actually engages the His-Purkinje system. That's why it's a slow slur. Very similar to the concept of delta wave in our accessory pathway location. If it's from the left ventricular outflow tract, it could be above or below the valve. If it's below the valve, Then you look at V5-6, there will be an S wave. That means the activation is from low to high. That means it is an infravalvular LVOT. And it's LVOT because it's dominant V1. How about the cusp? In the cusp, it may actually still exist like a right bundle branch block. So the S wave is still deeper than the R wave, but the R wave is abnormally fat or abnormally tall. So if the R wave, the RS amplitude index is more than 30%, that means the peak of the R wave compared to the S wave is more than 30%, or it's a fat boy R wave, that means the R wave duration is more than 50% of the total QRS duration, then although it's by definition left bundle branch block morphology, that means the S wave is still deeper than the R wave, this suggests the origin of this ectopic is actually coming from the left side of the heart and likely to be an aortic cusp origin. So this is my schema if I'm looking at a patient who have got an outflow tract type tachycardia. We may be thinking of RVOT or an LV summit. We start off with looking at the left-hand side, left bundle branch block inferior axis. If it's genuinely that, it's likely to be RVOT, right ventricular outflow tract. Maybe easy. It could be hard sometimes. But if it is a dominant R wave in V1, that means right bundle branch block inferior axis, then I would look at whether there's an S wave in V5-6 or not. If there's an S wave in V5-6, then it's likely to be an infravalvular LVOT. So for both RVOT and infravalvular LVOT is in the muscle. That means it could be endocardial or epicardial. So then I will look at the MDI at V3. If the MDI is more than 55%, then it may be epicardial. And we'll come back to why that is important. If S wave is absent in V5-6, then it's likely to be a supravalvular LVOT. And as we mentioned earlier about the left bundle branch block morphology in V1, but there is a suspicion that you have a fat boy R wave, or the R wave is starting to be a bit taller than you expect, the RS ratio more than 0.3, then this is likely to be an aortic cusp. That would help us in actually preempting and thinking that we may need to move out of our normal mapping area. But what is a normal mapping area? I think as with most electrophysiologists for addressing outflow tract VT or ectopics, we would be using mapping system. Even though it may be coming from the left ventricle or the cusp, I would always have the right ventricle as my first map. It's relatively fast, especially now if you use multipolar catheter, you can draw up a map very quickly. That gives you your first anatomical location, the right ventricular outflow tract. Following that, I would normally go to the coronary sinus because, especially if your MDI is high, then it may be an epicardial source. That means I need to map the anterior interventricular vein. And this is my approach, to put a good sheath or catheter in there to do an angiogram of the coronary sinus angiogram. And of course, when you're thinking about mapping or ablating there, you need to know how close you are to the coronary arteries. So a coronary angiogram is also important. This is an example of ablation of a site. You can see the ECG suggests a left ventricular source. V1 is positive, and it is outflow tract because 2, 3, and AVF are positive. And the earliest intracardiac signal is actually found along the anterior interventricular vein. Mapping the cusp, it is important to know where the coronaries are, the right coronary artery and the left coronary artery. Doing an angiogram, it would be good to light up the aortic cusp so that you know how much playground you have, how much space you have to map the cusp. So after the RVOT, after the coronary sinus, I'll be mapping the aortic cusp and the LVOT, guided by coronary angiogram. Thinking about this area, as I said earlier, this could be a tiger country because you've got coronary artery next to it. There is this continuum between the cusp and the left ventricular summit. It's quite a complex anatomy. It's in a three-dimensional space. So we need to think about also difficult cases, especially giving us ECG markers. You may be in for a long day or long morning in the lab. There are three scenarios that I'd quite like to highlight. The first one is the Q wave in the AVL compared to AVR. The second is what we call a pattern break in V2, and the third one is the QR in V1. If you look at the Q wave in AVR and AVL, this paper by Lin in 2016 highlighted there is a difference when you move from the cusp, which is the ASV, to subvalvular LVOT, to the anterior interventricular vein, to the epicardium. As you move towards the epicardium, the AVL Q wave is more deep than the AVR Q wave, suggesting it may be moving towards the epicardium. And this is the Mashinsky group showing the pattern break in V2. So if you move from V1, which has a R wave, you can see, moving to V2, the R wave seems to either disappear or get smaller before going to V3, and it starts to come back up again. So this is a V2 pattern break, which is a bit of a nightmare because you know that the source of the ventricular ectopic is actually quite deep and not easily accessible. It is in that trigone area between the anterior, the left LAD or the left anterior interventricular vein, or the obtuse marginal branch, the triangular area there. This area also has a lot of fat, so they're not easily accessible epicardially, even you want to do it surgically or do an epicardial subxiphoid approach. And the long-term success is actually not that great, and sometimes you may need to address it from the right ventricular outflow tract in order to access that area. The QR in V1 is a signature. You've got a small q and a tall r, and that is a signature for the aortomitral continuity. And now with good mapping tools, we actually know exactly where it is, but accessing the area, which is deep in the muscle, is also quite challenging. So when we are doing mapping, what's the approach? I think activation mapping is the best mapping approach because you are seeing the clinical arrhythmia and you want to get to the earliest point where you can ablate. Less good is pace mapping. I'm sure we've done pace mapping for a long time, and to try and guide us into the area which is in close proximity to the source. But pace mapping can give us an error of about 10 to 15% of the area, because you can get exactly the same 11 alpha 12 or 12 alpha 12 ECG match in the proximity of that area, maybe up to a centimeter squared. So it is not the best mode of mapping. What is good is actually the unipolar signal to guide our mapping. If you get good unipolar signals, if you're at the source, you will register a very deep QS complex as a unipolar signal at your mapping catheter. A source that is on that location but deeper in myocardium will register a slow slur of the QS. You don't get as sharp a QS as you will get if it is endocardial. And this is lessons learned from the EnSight array system, which is non-contact mapping, no longer available anymore. But it taught us a lot about unipolar signals. So again, early, deep QS is good. As you move away from it, you get a slow slur in QS. And if you move even deeper on the other side, maybe epicardial surface, you start getting an R wave. And if you are on a different chamber, your QS will be very late. So this helps us in identifying whether you are on the spot or not. Another signature, which is very helpful, especially in sources which is around the aortic cusp, is this notion that you have a late potential. I don't know if you can see that at the bottom in the distal coronary sinus. you have a late signal during the sinus beat, which is what happens when during the sinus beat, your activation into ventricle, you have retrograde conduction through that fascicle back up to your mapping catheter in the cusp. So you register late potential. But when you have an ectopic that comes from the source, or VT that comes from that source, the fascicle will fire and will then be early. So this late potential in sinus rhythm will then be brought forward. So this is quite a specific sign. If you see that, you know you're going to get that aortic cusp VT. So pulling it all together, we can put it into a mapping system. Nowadays, they get very nice signals to give us that location, the earliness, the unipolar, the late potentials that become early in the ectopic, and success rate is normally quite good, even in cusp. Another new mapping tool that helps us decide where to go or how easy it is called Vivo. This is a software platform developed by and bought by Catheter Precision. It uses the digital ECG of the ectopic, either in the lab or you can do it with a 12-lead Holter. If it's digitized, you can put it into the system, and you can also input the system with the patient-specific anatomy of the heart with either a CT scan or MRI. And then at the time of procedure with the ECG electrodes, you can do a tomogram picture of the chest, and the software will then generate isochrones and identify the earliest point of that ectopic. So this is a movie of that. It's not showing very well, but you can see that map there on the left-hand side showing the earliest point there in the outflow tract. And as you peel back the myocardium, you can see that this is an epicardial source, and this was actually ablated at the great cardiac vein AIV junction. So this can help pre-procedural planning, and during the procedure, you can incorporate this map, which is in the DICOM format, into your mapping system. It can go into CARTO, you can go into EnSite X, and this is EnSite X example, and with very little mapping, you can actually locate that source and ablate that. So what ablation parameters? I think most people would now use irrigated system rather than a non-irrigated ablation platform in RF. In the outflow tract free wall, RVOT, where the myocardium is thin, or in the coronary vein, naturally we can't deliver too much power, maybe 25 and 30. In the outflow tract septal wall, you can use a bit higher, 40 watts maybe. And if it is a thick muscle, you may go up to 50. I would also go higher if the myocardium source seems to be deeper. And how deep is deep? And why is there deep? Because especially in the area of the cusp, if you look at this beautiful anatomy example from Shiv Kumar and colleague there, you can see the beautifully lit up figure of the area between cusp, where you have the interleaflet triangle. So this is fibrous tissue upon fibrous tissue. So you can imagine your catheter is sitting on the fibrous tissue. You're trying to burn myocardium, which may be 2 doors away from you. So it is not surprising that you need higher power to penetrate into that area to hit the muscle, because you're burning over 1 layer or maybe 2 layers of fibrous tissue. When we were using non-irrigated ablation catheter, we were looking for an accelerated response, like we look for accelerated junctional rhythm for AVNRT ablation, slow pathway ablation. But for irrigated ablation, we don't normally do that. We would expect almost total absence of the ectopic when you switch on the energy, because you are almost chopping the head of the chicken without giving it a chance to squeal or scream before you kill it. So, difficult outflow tract ablation is difficult because the source could be very deep in the muscle, in the area that your mapping cannot reach. You may have different areas very far apart with equally early signals. So that is a sign that you're early but not at the earliest. So the NeoK group has highlighted this, and that difficult ablation, you really need to know your anatomy. And it is an anatomical approach which may be ultimately, which is going to give you success. What do I mean by that? So as I said, my default first mapping approach is the RVOT. I always have the RVOT as my base. Although I may not ablate there, but at least I know how early RVOT is. If it's on the left, clearly RVOT is not going to be early, but it gives me a map. Then I will go to the AIV. That gives me another location as to how early it might be. I will go to the cusp, and I will go to the LVOT. So these 4 areas will give you, by comparison, what is the earliest. So quite often, not surprisingly, if it's deep in the muscle, in the septum, or in the aortomitral continuity, you have equally early signals in different locations. So you know that you need to blast deeper. And that's when you would consider using higher energy, either at the cusp or in the infravalvular LVOT. But in the very extreme situation, you need to consider even more extreme approach, like using a percutaneous epicardial approach or direct surgical ablation. But I've told you that this area has got a lot of fat, epicardial fat. So that's not my preferred option. I've not thought of a situation where I've succeeded in using this approach in these circumstances, especially in the pattern break V2 situation. You can use bipolar, put 2 catheters, but hook them together, the 2 ablation catheters, and ablate across the different chambers. Or you can use half saline, a transvenous ethanol ablation or needle catheter. Needle catheter is not readily available, but this is being developed. But these are really extreme measures, and they are not really the really answer to all questions. So my go-to would be to go to my earliest spot and safely deliver high energy. I can use 60 watts. I've seen myself using 70 watts if it's really deep in some extreme situations. So to conclude, I think we've seen that outflow tract tachycardias form the bulk of the normal heart VT that we see clinically. Quite a lot of them we now recognize are originating from the LV summit. ECG algorithms can help us identify and locate them even before we go into the lab. And appreciation of anatomy, I think, is key. And detailed mapping of the different chambers will give you the anatomical source of the arrhythmia. And these can be ablated at the RVOT, through the coronary veins, aortic cusp, or the AMC. And with that, I'd just like to thank you again for the kind invitation. This is where I come from, Leicester. You may have heard about Leicester from our glorious days in 2016, winning the British Premier League from a 5,000 to 1 odds. We lost, and we were relegated to a championship this season, but thankfully we've just won the championship, and we'll be going back to the Premiership in the coming season. Thank you for your attention.
I think we had the opportunity to hear an amazing lecture. Even for us that we are not electrophysiologists, it's the first time that I feel that I understood something about the ablation, especially in these challenging cases of the LV summit. I think it was really helpful for all clinical cardiologists, except from your expertise audience, that they know the electrophysiology better than we do. I don't know, although we don't usually do for lectures questions, I think that Professor Vasilikos will have to make one from Thessaloniki. Professor Vasilikos.
Hello. It was a great honor and an excellent lecture. Thank you very much. And I would like to ask a simple, looks like a simple question, but it's not a simple question. And always I ask the same question to me. When I see a young patient who comes, there is a suspicion that the focus of his ectopics is LV summit. And for example, let's say he has 25,000 VPCs per 24 hours. He is relatively asymptomatic because it was discovered accidentally. What is your threshold to put this young lad to the cath lab? Or in other ways, when you start, what is your threshold to stop? And I'm not talking about somebody who has VPC tachycardiomyopathy or there's organic, the accidental ECG finding, but lots of ectopics, and you have a young guy, and you don't want to put this person to threat,
Yes, absolutely. Very, very good question. I think this is very appropriate, for clinically how we actually manage these patients. So I presume the premise is that the heart is normal, so echo is normal, and the patient is asymptomatic, and you find lots of monomorphic VT or unipolar, single morphology ectopics. So I think the main question is, we've known for a long time that ectopic frequency of less than 5% is probably safe, but more than 10% is probably not safe. But I think we've got quite good evidence that has now traveled to guidelines, and I normally use a 13% cutoff. And that was based on one of the studies about 3-4 years ago to show that the 13% in patients who are developing ectopic-induced cardiomyopathy is, if you ablate them or control them with good medication, then they regress. So 13% is my cutoff without any symptoms. With symptoms, it's a different thing. But before that, I will also need to satisfy myself that there's no cardiomyopathy or myocarditis there. So I would do an MRI and look for late gadolinium enhancement to make sure there's no cardiomyopathy. So, but that's what my practice is. I would do a 24-hour tape, do a ventricular ectopic burden. If it's more than 13%, I would counsel the patient and say they are better off with an ablation. Okay. And another thing that I would normally do is an exercise ECG, which we don't do anymore. We rarely do exercise ECG for chest pain. We send everybody for a CT scan. But the exercise ECG response also would guide me as to my approach during the EP study. So if it's ectopic that's juiced up by adrenaline, by exercise, then I would have somewhere to start, probably using adrenaline to induce ectopics on the table. As we know, it's very frustrating. Sometimes patients can have a lot of ectopics walking around, and then they have none when they're lying on the table. So that's why, again, the Vivo may be quite helpful as a pre-procedural ambulatory Holter ECG. You can digitize it, feed to Vivo, and give you at least a location to start with.
So we'll give the 13% threshold and the exercise ECG that would guide us. I think also my co-chair has another question.
Just one question from my side, Professor. Do we have any long-term data regarding, for this kind of procedures, regarding arrhythmia recurrence? Regarding arrhythmia recurrence, long-term data?
I think historically it's about 5%.
Okay.
But that is quite old data, and that is probably more because of the fact that the patient were not inducible on the first time, quite a lot of the RVOT. So I think long-term data of the difficult ones, you can see the Mashinsky paper, long-term suppression is only 58%. But if you look at normal heart VT as a whole, that's what we normally quote to patients, about 5% recurrence.
Okay. I think we came to the end. We can go to the dinner. We really thank you for your marvelous lecture.